never got deleted off the track changes. So I gave that one back. So you got that one back. Um, so we're gonna trial this. I didn't get very far. I don't like the way this one looks. I think it'll be a lot better for physio where it's a lot more like drawings and stuff like that. This is all very straightforward, but um the way that if you ever have any feedback on this stuff, please let me know. I want to go through this really fast. These all say hypo, but they're stickers, so you can like use them as like a review. Like you just touch it. It should go away. Why is it not now? There. Oh, I took away some. They're supposed to be able to come away. It works on yours? Okay. I don't know why it's not working on mine. My pencil's in the way. It worked before. Okay. It works on yours. So basically, these are just flashcards. You just take away one, it tells you what it is. So the first one, obviously not working. I don't know why. There we go. Okay. So from the hypothalamus, corticotropin releasing hormone goes to the anterior pituitary and releases ACTH. And then ACTH, target tissue is adrenal cortex. And you keep going down, and the end is the cortisol, aldosterone, and your other androgens. So you can use these as like little flashcards as you're studying. Next one, TRH, thyrotropin releasing hormone. That's going to go to the anterior pituitary to release TSH, and so on and so forth. Your thyroid eventually will release T3, T4. So this will always be there. We have all of our anterior hormones. And then on the right side, we have our posterior ones. So GnRH, gonadotropin releasing hormone, goes to the anterior pituitary to release your LH and FSH, which then are going to go to your gonads to release your testosterone and estrogen. Our prolactin releasing hormone, it's there. We don't really do much with it, but we know that it's going to release prolactin in the anterior pituitary. Prolactin is going to target the breast tissue for milk production. Okay. And then we have our growth hormone that tells the anterior pituitary to release the growth hormone. Growth hormone targets your bones and your muscle to cause growth for all that stuff so we can continue growing. Posterior pituitary is only two of them. Oxytocin, the target is breast, but it also has another target. Where else does it hit? Only during certain parts of like life. Uterus for uterine contraction, for start labor, and then also to uterine atony to stop the bleeding after delivery. So that's what oxytocin is for. And then milk contractions and milk let down. So remember, prolactin develops the milk. Oxytocin lets it down, squeezes all those ducts to let the milk flow. The other one is our ADH, goes to our kidneys, and that is going to deal with water retention and vasoconstriction. So those are our basic breakdown of our anterior and posterior hormones and their flow. So we're going to first focus on anterior pituitary tumors. Okay. Pituitary adenoma is the most common benign tumor there is. 10% will have a pituitary adenoma at the time of death. So 10% of people will have some form of a pituitary adenoma. Some will secrete more than one pituitary hormone. So we know we have different types of tissue types within the pituitary gland. Sometimes they will secrete more than one of those growth hormone, prolactin. It'll be a mixture. Non-secreting tumors, okay, don't make any extra hormones, and then we also classify them by size. So a microadenoma is less than 10 millimeters. A macroadenoma is greater than 10 millimeters. As far as the types, it all goes by whatever tissue is being affected. So if it's a somatotroph, it's a growth hormone secreting tumor and so forth. So know the type of tissue. Somas, body, lacto, well, there should be a T there. Milk, corticotrophins go to the adrenal cortex, gonadotrophs to the gonads, and thyrotrophs. So we talk about cancer, you want to know what type of tissue is being affected by that. The signs and symptoms depends on the type of tumor, but for the most part, headache, nausea, vomiting are the big ones. Some altered consciousness. They're going to have this type of field of vision called bitemporal hemianopsia, where they get tunnel vision. The peripheral vision is gone due to the crossover in the optic chiasm. The pituitary gland swells, compresses that optic nerve, and we get that type of vision. Treatment. A lot of the treatments on this side of endo are all going to be number one, go to endo for the most part. A lot of them go to endo as the first line, but that won't be an answer on your exam. You have to know the rest of it. So usually it's going to be go to endo, but we have to know the rest. Medical treatment. We give them cabergoline or bromocriptine. These are dopamine agonists. Okay, so that's what we can use. If they're not responding to the medical treatment, the bromocriptine, then you can start doing surgery. You can do a transphenodal approach, and we'll show some pictures of that in a second here. So this is what it looks like. We'll go to the pictures first. So there's our pituitary adenoma, obviously space occupying lesion, very, very big right there. One of the consequences you may see frequently is called hyperprolactinemia. High prolactin, if you're having a tumor that's secreting prolactin, and the prolactin tumor is the most common one, what are we going to see with hyperprolactinemia? There are 3 causes of ways to get hyperprolactinemia, high prolactin levels. There are physiologic causes: exercise, pregnancy, breastfeeding, nipple stimulation. So nipple piercings will constantly stimulate it. Stress and trauma will cause prolactin to go up. Pharmacologic causes. These are other ways to get your prolactin levels raised. Amphetamines, cimetidine, ranitidine. What are those two? H2 blockers. They can also cause hyperprolactinemia. Estrogens, opioids, nicotine, verapamil, and cocaine will do it as well. So when you're figuring out, will they have high prolactin levels? Why do they have high prolactin levels? These are some of the reasons that it could be. Pathologic causes: chronic chest wall stimulation, post-mastectomy. If you've had herpes zoster, chest acupuncture, nipple rings, these are all things that are chronically stimulate the nipples, will cause hyperprolactinemia. Cirrhosis, renal failure, these are more your systemic causes. Multiple sclerosis is here, spinal cord lesions, and lupus. Lupus is kind of like in everything. It could be a lot of different things. So these are some causes of hyperprolactinemia. As far as our workup is concerned, this is one of the cases, I know I've told you guys in the past, I hate when people just draw a bunch of labs and just see what elevated. This, you have to do that. Because with the pituitary gland, you don't know which hormone in the pituitary could be causing you that problems. They may show up with one, and if they have one, they may have others. So all the labs that we're doing are checking all of those hormones from the anterior pituitary. One, we just make sure they're not pregnant. We get TSH and free T4. That's going to make sure our thyrotropes are okay. We get our BUN and creatinine. We get our liver function. Look at our enzymes, calcium, platelet looking at our kidney function, enzymes. If a male has hypogonadism, we're going to talk about that on Thursday. Check testosterone, LH, and FSH, because if they're having testicular atrophy, it means they're not being stimulated to do anything. What stimulates the testes to do something? The LH and FSH. So you have to work backwards and see what's going on. Females, check your serum estradiol, the estrogen, LH and FSH, and obviously your serum prolactin levels, and see if they're elevated at all. MRIs are the best choices. CT scan if they can't tolerate it. And again, treatment for this is going to be the bromocriptine, the cabergoline, these dopamine agonists. And if they can't do that, then we do surgery and basically go right up the nose, just like the Egyptians. And pituitary glands right there, and they can resect the pituitary gland. That is really it on pituitary adenomas and hyperprolactinemia. Any questions about this one? Okay. Now we're going to talk about anterior hypopituitarism. When you're studying endo, just with each hormone, is it what happens to our body when we have too much of it and what happens when we have too little? And that's all you got to know for each hormone, what we go through. When we have too much anterior pituitary hormone, we have all this. When we have too little, we get this. So this is anterior hypopituitarism. And in this case, they're going to lose one or any combination of our anterior pituitary hormones. Panhypopituitarism is loss of all the hormones. So pan means across. We're going across, all the hormones are gone. You can also have pituitary insufficiency, where it's a decrease in function of one, any, or all of the hormones. What can cause this hypopituitarism? One is congenital. We have this Kalman syndrome, where they get delayed or absent puberty and they have a lack of smell. I don't know where the lack of smell comes from with that one. Maybe you'll learn that in peds, but I don't know why they have smell. Acquired causes, trauma, cranial radiation, surgery, strokes, postpartum. You'll see it. We do that a lot later on today, called Sheehan syndrome, where after they deliver a baby, they get an infarct in the pituitary gland in the vessel, and there's no blood going to the pituitary gland, so it atrophies and dies off. You'll see that again. In order for it to be a Sheehan syndrome, I have to mention something about postpartum, delivering a baby very recently. Those are the keys for that. And lesions and tumors, the most common is a pituitary adenoma that would cause you to have this panhypopituitarism, or low pituitary output. So again, signs and symptoms, it depends on what hormone they're deficient in. If they're deficient in FSH and LH, they're not coming out. Hypogonadism, delayed puberty, decreased body hair. They just delayed puberty. They're not going to have the hormones to have them go through puberty. It's not going to happen. If the thyroid trophs are affected, then you'll have your deficiencies in your thyroid function. If it's ACTH, then you got decreased cortisol because nothing is telling the cortisol to come out. So just remember the pathways. If you affect something upstream, what's going to happen downstream from that? Growth hormone deficiency, what happens in adults, we'll go through that in a minute as well. So again, with this, it depends on what symptoms they're having when they present to you. Labs. You got to do it all to find out which hormones are deficient. We have to check all the pituitary hormones, the anterior and the posterior side as well. So posterior side, we got to bring in ADH and oxytocin. Labs, we want to check glucose, sodium, and potassium. What hormones are we checking with glucose, sodium, and potassium? Cortisol is one, and aldosterone. They're going to affect those things. UA, LFTs. We get our testosterone levels in males, see what that's doing. Check your thyroid, all your hypothalamic releasing hormones, you can check those as well. Because if the pituitary is not working, well, what tells the pituitary what to do? Hypothalamus. So check the hypothalamus to make sure you're not having any, if the hypothalamus is the culprit, what type of problem is that? Primary, secondary, or tertiary? Tertiary, very good. Why are we checking somatostatin? What does that do? Stops things. So we want to know what that's doing as well. X-rays. We do X-rays of the chest, skull, hands, and wrists just to look for bone aging. Okay, they're going to have a lack of cortisol, and lack of cortisol leads to bone problems. So check it for that stuff as well. MRI is always the best thing to do for any type of pituitary problems. But again, if there's any contraindications to the MRI, you can do the CT as well. Complications from this, visual problems, your hypoadrenalism, this adrenal crisis is a really, really bad one. I think Dr. Wood tell you a story that, did he tell you a story? Patient his wife just saw had like no pituitary function either. We were just talking about it like 2 seconds ago before you class. I thought he told you guys. He said he told you, but maybe not. Someone coming with adrenal crisis, they're not having any cortisol, no aldosterone. They're going to be like weak, obtunded. You need fluids. We're going to get through all the adrenal stuff next week. And fever shock. These are all related to the adrenal crisis, not having any cortisol. Treatment and management. Again, refer to Endo. That won't be an answer, but it's there. We have to get them. They have to go see Endo. First line, replace the hormone. So whatever hormone they're deficient in, just give it to them. If they're deficient in growth hormone, you give them growth hormone. If it's deficient in thyroid hormone, you give them Synthroid or levothyroxine. If they're deficient in ACTH, you give them prednisone, which is the cortisol. If you feel they need the aldosterone boost as well, you can give them another drug for that. So it's just whatever they're missing, you just give them. If they're missing all three of those, you give them all three. And then you go from there. So you just replace whatever hormone is deficient. Surgery, again, that's transsphenoidal approach again to get through and get any tumors out. Similar to what we discussed in the last slide. Patient education, wear medical alert bracelets. They could be coming in with coma and shock. And if they're alone, they can't give you a medical history, but if they have a bracelet that says, I have, Addison's disease or adrenal crisis, then when they come into the ER, we can give them cortisol right off the bat, just give it to them and see how they do from there. So that's really all there is about this anterior hypopituitarism. Look at what symptoms they're presenting with, what hormones match those symptoms, get your blood work done, see what you're deficient in, and just replace those hormones. Any questions about hypopituitarism? This is the last one. This is where I kind of stopped, but you get the idea. We'll go to the PowerPoint. We'll zip through next. So growth hormone deficiency. So these are people who don't have a lot of growth hormone. So let's review a little bit about growth hormone. Has two actions, indirect and direct. The indirect, this is where your IGF-1 comes in, because growth hormone causes IGF-1 to be released. So IGF-1 gets released, and that goes to your skeletal muscles. The bone causes the growth to occur with it. The direct anti-insulin actions causes cortisol to be released. So if cortisol goes up, what's going to happen to our blood sugar with growth hormone? Goes up as well. We just talked about diabetes, and we talked about growth hormone. What problem can growth hormone cause for AM hyperglycemia? the dawn phenomenon. Okay, when they wake up in the morning, cortisol, growth hormone go up. Well, growth hormone is up all night. Growth hormone, cortisol spikes in the morning. Cortisol, growth glucose goes up, and you wake up in the morning. So etiology of growth hormone deficiency. About 1 in 7,000 kids have short stature. 20,000 children get growth hormone therapy each year. About 35,000 adults also get growth hormone deficiency later on. Growth hormone deficiency in children is before age 3. And in adults, it usually goes along with a pituitary tumor discovery. And usually in adults in their 4th and 5th decades is when a growth hormone deficiency may occur later on in life. In children, physical exam, height 2 standard deviations below the median, growth velocities below the 10th and 25th percentile. So we'll go through the growth chart in a second. They're going to have increased subcutaneous fat around the trunk. The face becomes immature, a prominent forehead. You start getting, prominent forehead. Dentition is delayed. Puberty is delayed. But again, you just give them the growth hormone, they will go back to normal growth. You can't make your kid a superhuman by giving them more growth hormone. It just makes them on a normal growth trajectory. They're not going to get bigger or anything. So a serum growth hormone less than 20 is very highly suggestive of growth hormone deficiency. So have you guys gone over these growth charts? So again, you'll do these on every visit in peds, and you want to see where do your kids show up on these charts, looking at growth and whatnot. And if they're routinely down here all the time, check growth hormone, see what's going on with that patient. Okay. A lot of this endo stuff is not, it's just very basic. Whatever they're missing, you just give it. And everything is symptom management. As long as their symptoms go away, they're doing okay. They start growing, getting on a normal projection, they'll be fine. All the facial features will go to normal. They'll return back to normal. That's where I ended that. Okay. Okay. So differentials, when they come in with growth hormone deficiency, adrenal insufficiency, hypothyroidism, and a genetic mutation. So look for dwarfism. Achondroplasia is the #1 cause of dwarfism. But again, this is not true dwarfism because you just give them the medicine, the growth hormone, and the features go away and they'll start growing again. Achondroplasia, they will not grow, or they grow to a certain point. So 20 is the magic number there. Now, just like in diabetes, we would do those oral glucose tolerance tests where we give you a bolus of sugar and we see how your insulin responds. You can also do these with growth hormone deficiency as well. So they recommend this insulin tolerance test as the standard test for diagnosis of growth hormone deficiency in adults. They also may have increased total cholesterol, LDL, ApoB, triglycerides, and HDL may be low in these patients. Imaging, get an MRI to look for tumors, anything congenital. Do your bone scans to see how the bone age is doing. You can do bone mineral density and do a cardiac echo to see how their ejection fraction is doing. Complications with growth hormone deficiency, premature cardiovascular disease, osteoporosis, psych issues, insulin resistance, and the obesity that comes along with it as well. Treatment, go to Endo, always going to be there. Consult a neurosurgeon if a pituitary tumor is present and that's causing the growth hormone deficiency. Neurosurgeon is the one that's going to take out the tumors in the brain. You can also get oncology on board if you think it's cancer and you want to go from there. But neurosurgery is the one that's going to do the actual surgery to take it out. And then your treatment, you just give them human growth hormone. You're going to restore normal growth hormone levels and reduce morbidity. And basically, it just enables short children to achieve a normal height. Anyone know what soccer player had growth hormone deficiency? Messi had it. Follow-up care with endo in children by assessing height, weight, and growth velocity. So again, are they trying to grow and go on a normal scale? In adults, get changes in body composition, exercise capacity, skeletal integrity, lipids change, and quality of life are monitored. Growth hormone therapy can be continued for adults if the benefits are observed. If there's no benefit after a year, to stop the treatment. Prognosis is determined by the response to the growth hormone treatment. And, it's a replacement to make short children grow at a normal rate. They're not going to get super tall. So that's growth hormone deficiency. Short stature, know the physical features in kids, what you see in very, very small kids, and then from there. Now let's talk about growth hormone excess. They have too much growth hormone. There's only two diseases that happen, gigantism and acromegaly. Which one happens in kids? Gigantism, acromegaly is in adults. What's the key factor in both of them? Growth plate closure. If the growth plate's still open, it's gigantism. They get really, really tall. Like that guy from UF, the basketball player, Taco Fall from UCF, they had it at some point. They're abnormally tall, but they're proportionate. They're not having the coarse features. They're just very, very, very tall. Okay. So this is Robert Wadlow, tallest person. He was 8'11" at the time of his death. And Andre the Giant, he was 6'3" when he was 12. Reached 7'4" when he was an adult. He knew he had a problem. He knew he could have gone on like the bromocriptine to stop the growth, but he chose not to, and he kept going. So gigantism itself is rare. Acromegaly is the more common one that you'll see. With acromegaly, mortality rate is 2 to 3 times higher than general population due to all the abnormal growth that goes on. The heart gets bigger, body gets bigger. All those other issues go on as well. As we start to normalize our IGF-1 levels, then they can start returning to a normal life expectancy. So we look at the IGF-1 level. And they usually die from cardiovascular or respiratory problems where it happens. So you can see the facial features here, this very, very coarse jaw that forms, these very coarse facial features. You can see this woman here over the years of her acromegaly. You can see the physical features changing, how the size of her hands got very big, the jaw, the mouth, the nose, all those features got very coarse and enlarged due to this acromegaly, too much growth hormone. Again, the key is secondary to IGF-1 excess due to the growth hormone excess. Growth hormone causes IGF-1 to be released. The tumor may cause headaches, visual changes for the optic nerve compression. So they start getting that bitemporal hemianopsia as well, that tunnel vision. Excessive growth of your hands, feet, jaw, and the internal organs as well. They get big. Soft, doughy, sweaty handshake where your hand like disappears in their hand, that type of thing. So IGF-1 is the key thing we're looking at when it comes to patients with acromegaly, and that's the marker that we look for treatment. Diabetes, sugar, A1C, that's how we know we're doing well. Thyroid, we look at TSH to make sure we know we're doing well. Growth hormone excess, we look at IGF-1. And as that starts coming back down to normal levels, then we know we're treating it okay. Signs and symptoms, again, everything has to do with growth, excess growth. Tall stature, feet get bigger. So they're saying, well, my shoe sizes are getting bigger. Normally, when you hit adulthood, your feet stop growing. They shouldn't be growing any bigger. But if you start growing, your rings don't fit anymore because your fingers are getting bigger. Those are all signs of excess growth. Hyperhidrosis, the sweating, they have that sweaty, doughy hand. They're always clammy. They may get carpal tunnel syndrome, paresthesias because of all the growth, soft tissue growth. It can start compressing nerves. So they get pain wherever downstream all that goes. Hypertension, sleep apnea, skull gets bigger, hat size enlarges, the teeth, because the jaw gets bigger, the teeth start to spread out from each other to occupy that space. You see their teeth starting getting spaces in between. Deep, coarse voice, even in women, because the vocal folds, they get thicker too. So it brings the voice down and deeper, husky. Here's your thyroid issues and the dilated left ventricle. Again, they all going to die of these cardiovascular issues. The heart's going to enlarge as well. And then just some more pictures you can see. Hand sizes. You can see the changes in the feet sizes from one person to another. And then the tumor right there. Labs, random serum IGF-1. Just see what it's like. Get your prolactin levels in case there is a co-secretion of a tumor. Some of these, you may have a tumor and growth hormone, but those lactotropes may be involved as well, and they may start pumping out a lot of prolactin as well. Here's our glucose tolerance test. Liver, kidney, get your calcium to see how the parathyroids are doing. Your thyroid function, echo, and an MRI. Make sure you don't have a pituitary tumor there or not. So here is the glucose tolerance test. Well, for what we do for growth hormone. So as we take the glucose load challenge, here we are. We can look after 3 hours. Growth hormone level measured at 16.3. The normal should be less than 5. So growth hormone is going up. It's a higher level than it should be. Growth hormone releasing hormone. Is the measured value with these patients lower or is it higher than normal? This is what they're measuring, 0.08, and the normal is 0.1. So are they lower? They're lower. Why does that make sense? That growth hormone releasing hormone will be low. Negative feedback. We have a lot of growth hormone in the blood. It's going to tell the hypothalamus we have enough growth hormone. We don't need any more. So GHRH levels drop because we have a tumor that's just secreting growth hormone without any suppression. There's no negative feedback. Our IGF-1 level, look how high that is compared to the normal. Because they're having all this excess growth hormone floating around, they're going to have elevated levels of IGF-1 as well. And blood pressure will be high as well because of all the issues with growth hormone. Am I going to ask you to memorize this growth hormone glucose tolerance after 3 hours? No. What do I want you to know? That it's going to be elevated because they have a growth hormone secreting tumor. IGF-1 is going to be high. GnRH or GHRH is going to be low because of the suppression that's going on from the growth hormone. So you can do this test if you suspect someone has growth hormone excess. You could do a glucose tolerance test. Instead of just checking glucose every hour, you're going to check after 3 hours, growth hormone, IGF-1, GHRH, and see what the levels are doing. Complications, we went through these already. Diabetes and glucose intolerance is the big one. Cardiac issues because of the increased size. Some thenar atrophy, vision problems, some cranial nerve palsies. They may have spontaneous hemorrhages, and obviously arthritis from carrying around all that weight everywhere all the time. Treatment, go to Endo. Remove the adenoma if it's there. Go to cardiology or ortho just to get baseline testing to see what's going on. Here is the treatment: dopamine agonist, bromocriptine and carbergeline. They bind to that pituitary dopamine receptor and suppress growth hormone secretion. You can also give octreotide, which is sandostatin, which is a form of somatostatin, which we know somatostatin stops growth hormone release. So there's two ways we can give it. We can either stop the growth hormone being secreted or prevent the dopamine from stimulating the release of it as well. So either one of those work. The dopamine agonists are the first line. You would try those first. Cushing's syndrome, we're not going to spend any time on it. We have a whole lecture just on adrenals that we'll deal with next week. Just remember that I bring it up here. Why do I bring up Cushing's syndrome in the pituitary lecture? ACTH. And remember that Cushing's syndrome is an umbrella term that encompasses a bunch of different ones. Cushing's disease is the disease of the pituitary gland itself. So if I say Cushing's disease, it's a pituitary problem. If it's Cushing's syndrome, it could be a bunch of other issues that we'll deal with next week. Nelson syndrome is invasive pituitary tumor, high-level ACTH. So they're going to get hyperpigmentation in Cushing's disease, usually following a bilateral adrenalectomy. Why do they have such high levels of ACTH? What don't they have anymore? Cortisol. They had a bilateral adrenalectomy, so it got taken away. So now ACTH is going to skyrocket because nothing is telling it to shut off. So they get this surge in ACTH. And should not occur if they had any irradiation done in the pituitary gland. But that's what Nelson syndrome is. High-level ACTH, hyperpigmentation. Why do they get hyperpigmentation with high levels of ACTH? And then remember what the molecule is. So remember, we have POMC, which dissociates to make ACTH and melanocyte stimulating hormone. So if I'm increasing the amount of ACTH that I need, I'm also going to increase my MSH, which is why they get hyperpigmentation going on. So the key with Nelson syndrome has to be status post bilateral adrenalectomy. That's how you get Sheehan syndrome, or Nelson syndrome. Signs and symptoms, again, high ACTH, high MSH, headache from that pituitary tumor, and some visual field loss. Labs, obviously ACTH, get your scan of the brain for pituitary adenoma, and you want to do an abdominal CT to evaluate your adrenal glands. Maybe something was left over or something's going on. Treatment, surgery, if they do have an adenoma there, take it out, and you can get some glucocorticoids to help with the lack of cortisol. Moving on to antidiuretic hormones. Now we're done with the anterior pituitary because the thyroid will deal with it on its own. All the cortisol will deal with that on its own. Obviously, we're not going to deal with the pancreas because we already did it the first unit. So we don't have to worry about the pancreas at all. So ADH from posterior pituitary acts on the kidneys for water reabsorption from the renal tubules. Also causes vasoconstriction. But we're more worried about it from the water side of things. So again, ADH, look at it in two ways. When we have too much ADH and too little ADH. So for all these hormones, look at it from both sides. What happens when we have too much? What happens when we have too little? So if you have high ADH, this is your syndrome of inappropriate ADH. If we have low ADH, decreased ADH, this is your diabetes insipidus. So diabetes insipidus can be central or nephrogenic. Central DI is decreased sensation of ADH causing polyuria, polydipsia, diminishing the patient's ability to concentrate urine. So in this case, they have low ADH. They're not secreting ADH from the posterior pituitary. That's central DI. So if they have central DI, if I gave that patient ADH, are the kidneys still responsive to ADH? Yes, so they're going to have an effect if I give them ADH. With nephrogenic DI, we have a resistance to ADH on the kidneys. The kidneys do not respond to ADH. So our pituitary is making it, releasing it, but the kidneys don't respond to it, so therefore we can't do anything with it. They both present the same way, but your job is to figure out why are they having it. Is it a problem with they're not releasing ADH or they're not responding to it? So as we go through, don't make enough ADH, so the kidneys make a lot of urine, so they are peeing like crazy. Decreased urine volume, increased urine osmolarity. So causes, 30% idiopathic, 25 due to benign tumors of the brain, 20% following cranial surgery, 16% head trauma. What's the key thing here? Anyone coming in with any type of head problem, trauma, tumors, surgery of the head, they are at risk for developing diabetes insipidus. So any head problem, trauma coming in, they're in the ICU. In the back of your mind, think about diabetes insipidus. History, polyuria, polydipsia are the big ones. They'll have like 3 to 18 liters of urine produced every day. They're going to have a predilection for drinking cold liquids, often water, because they're very, very thirsty. So they're just drinking like crazy. Neuro symptoms will vary with the patient's access to water. If the patient have free access, they won't have any symptoms at all. As long as they're able to drink, okay, they'll be okay. When they don't have access to water, then you get problems with sodium levels and you start getting some neurological problems. So diabetes insipidus, water is okay. They can drink it. SIADH patients can't drink water. We'll go through that in a second. So with those patients, you got to be careful. Physical findings varies with the severity of the DI. Physical exam may be normal. They may get hydronephrosis, bladder enlargement because of all the excess urine that they're producing. The bladder's got to store it. It's going to get bigger because you're producing a lot more urine. You may get some water on the kidney, the hydronephrosis, because the bladder's full, but the kidneys are still making urine. It gets backed up the ureters and back into the kidney. And they get some signs of dehydration. However, besides dehydration and an enlarged bladder, there really are no specific signs for diabetes insipidus. So polyuria, polydipsia, nocturia, dehydration are your big signs and symptoms for this. Differentials, diabetes is one by itself, just diabetes mellitus, high salt intake, psychogenic polydipsia, Cushing syndrome, corticosteroid treatment, and lithium are differentials that will cause similar symptoms to the presentation for DI. Labs, get a 24-hour urine collection. It should be elevated because you're peeing all the time. So these jugs will be filled. You have a lot of volume of urine. Check the urine for your electrolytes, glucose, get your serum checks, your lithium levels. Water deprivation test, we'll talk about that in a second. Check your ADH levels. See what they're doing. What would they be with diabetes insipidus? Low. They're not making anything. And check your brain MRI because, again, like 75% or 70% of all the patients coming in with DI are going to have some sort of head problem, trauma, post-surgery, something going on with the brain. So the water deprivation test. How do we do this for patients with suspected DI? So we want to ensure adequate dehydration and maximal stimulation of ADH for diagnosis. So we withhold all the water and we check your urine and body weight. We check it all. We give 5 units of ADH sub-Q. So we give you ADH and we see what happens after an hour. Give you ADH, an hour later, we check urine again. If the patient has central DI, the pituitary is not producing the ADH. The urine does not become concentrated, but in response to exogenous ADH, the urine osmolarity increases by 50%. So the kidneys are responsive to the DI. You're just not making ADH. You're just not making any ADH. So you do see changes in the urine if they have central DI. If they have nephrogenic DI, the kidneys will fail to respond to the ADH that you gave them, and there will be no changes in the urine. So nothing is going to happen with nephrogenic DI because the kidneys are not responsive anymore to ADH, and they're not going to do anything. So some clinical pearls regarding DI. Non-specific gravity of urine of 105 or 1005, and a urine osmolarity less than 200 are the hallmark of diabetes insipidus because it's just tons of water in that urine. It's diluting everything out. And again, your plasma osmolarity is usually greater than 280. So you're going to have an ADH deficiency, very hypotonic urine, polydipsia. They may get hypernatremia if intake is inadequate. So if they don't drink enough water, what happens to their sodium levels? Starts to go up because we're removing the solvent or the solvent. The water is being removed. All those electrolytes start having a bigger pull. Complications of DI, a dilated urinary tract, just due to the sheer volume of urine that you're producing. Dehydration, hypernatremia, impaired mentation, that's probably secondary to the hypernatremia that they're having. Treatment, again, I'm not joking, endo, neurosurgery, but first line, just give them desmopressin, which is the DDAVP, which is ADH. You can give it oral, injectable, nasal sprays. Vasopressin is the second line. But again, these are for patients with diabetes insipidus. They're not making any ADH, mainly with central, because if they have nephrogenic DI, are they going to respond to this at all? Nope. So only central is what you treat this. Any questions about diabetes insipidus? That's too little ADH. Now let's go to the other extreme, too much ADH. In this case, we have hyponatremia, not hypernatremia, hypoosmolality from inappropriate continued secretion of ADH. So decreased urinary output, whereas DI had a lot of urinary output. With SIADH, they're not, because now they have too much ADH, too much antidiuretic hormone, and they're going to hold on to all that water. Hyponatremia due to excess water, not deficiency of sodium. The sodium here got diluted out and it dropped. That's why these patients, you have to restrict their water. The SIADH patients can't drink a lot of water. So SIADH is the most common cause of euvolemic hyponatremia in hospitalized patients. Euvolemic, their volume status is normal. They're not changed at all, but they're still hyponatremic with that volume status. Signs and symptoms, progressive hyponatremia with fewer symptoms than is like slowly progressive. You don't want to have rapid changes in serum sodium. Sodium, don't go crazy with repleting it, not too fast. Sources of excess fluid should be evaluated. So cut out all water. They're usually on like like 250 to 500 mLs of water a day. That's all they're allowed to drink. There'll be signs on their doors so that anyone walking into the room will know they're on a water restriction. Don't give them any water. Some other findings you may see may only be due to the hyponatremia that's going on. That's what's causing the symptoms. So they'll have some confusion, delirium, some muscle weakness, myoclonus, some neural problems here, seizures, comas, all due to the sodium fluctuations going crazy. There's this Barter-Schwartz criteria looking at different things when it comes to SIADH. Hyponatremia with hypoosmolality. Continued renal excretion of sodium. We're still going to get rid of it. If we were really that low in sodium, we wouldn't get rid of the sodium in the urine. Urine less than maximum dilute. Absence of clinical evidence of volume depletion. What are some signs of volume depletion? Hypotension, tachycardia, those are signs of hyponatremia. Volume depletion, I'm sorry, not hyponatremia. Absence of other causes of hyponatremia. You've ruled out other reasons why they may be hyponatremic, and you correct the hyponatremia by fluid restriction. Don't let them drink water. So when it comes to the causes of SIADH, there's 4 categories. Nervous system problems, neoplasia, cancers, pulmonary diseases can also cause problems with ADH, and drug-induced. Those are the 4 categories for SIADH. Whereas for DI, it was all brain, head trauma, surgery, those things. With SIADH, it could be other things as well. Other tests you can do, again, you're just looking at volume status, electrolyte status, kidney status, and so forth. Imaging study, chest radiography to see if there's a pulmonary cause. When we talk about the adrenals and we talk about Cushing's, we're going to talk about these pulmonary cancers that can cause problems with those diseases as well. CT, MRI of the head, looking for any type of disorder, any lesion in the brain that can cause any issues with this as well. Any type of structural damage, CNS disorders, and so forth. Cerebral edema is always an issue whenever you're talking about sodium replacement, so be very careful with that. So the treatment depends on the following. How bad is their hyponatremia? How symptomatic they are? Is it acute or chronic? And how are their kidneys doing? Can the kidneys even get rid of the extra water if they wanted to? If they have, renal failure on top of this, they're not going to be able to get rid of the fluid anyway. And now you're doubling on top of that with SIADH, you're going to be severely volume overloaded. In a chronic asymptomatic setting, fluid restrictions, you can give vasopressin. If they're not available, you can try some loop diuretics with some increased salt intake to try and get that stuff out. In an emergency setting, be very careful with the treatment of hyponatremia against the risk of central pontine myelinolysis. Again, swelling of the brain. Anytime you talk about sodium, we even talked about it a little bit with the glucose replacement. Be careful with lowering glucose too fast. You cause cerebral edema. All these osmotic shifts are going to cause water to go different directions and cause swelling. So treatment, if they have severe symptoms, seizures, stupor, coma, okay, regardless of the degree of hyponatremia, they're having neurological problems from the alteration in the sodium. You have to treat it. And anyone with moderate to severe hyponatremia, less than 48 hours. Here's the goal. To correct the hyponatremia that does not cause neuro complications. So here's the goal. Raise serum sodium by 0.5 to 1 MEQ per hour. So 127 to 128, so on and so forth. Not more than 10 to 12 in the first 24 hours. So you don't want to raise sodium very, very fast. It's a slow, gradual rise because you want to avoid that central pontine myelinolysis, those neurological complaints. So very, very slow with the sodium. Complications in SIADH. Here's our cerebral edema when you raise the osmolality too fast. Non-cardiogenic pulmonary edema can also be there. Here's our central pontine myelinolysis from rapid correction of sodium. They get disorder of the upper motor neurons, spastic quadriparesis, pseudobulbar palsy, mental disorders, confusion, a coma. These are from central pontine myelinolysis from raising sodium too fast. And there's obviously risk of death with people with liver failure, potassium depletion, burns. Always be careful with people who come with large burns. They lose a lot of fluid. Once you start the path of the central pontine myelinolysis, there is no treatment for it. So don't start it. Just be very careful with the sodium replacement. The prognosis correlates with the underlying cause. So what was the cause that put you into this SIADH? And any neural effects from that hyponatremia. So rapid, complete recovery tends to be the rule with drug-induced SIADH. So if it was a drug that caused it, once that drug gets out of your system, the SIADH goes away. So that tells you it was just drug-induced. Treatment of that pulmonary or CNS infection will also help with the SIADH. If they have neurologic symptoms or severe hyponatremia, may develop permanent neural impairment. And obviously, if you raise it too fast, you get that risk of central pontine myelinolysis. Okay. We're almost done. A couple more slides. So this is your summary looking at the two. Diabetes insipidus, very, very high urinary output. There is no anti-diuretic hormone. Nothing is telling the body to retain the fluid, retain the water, so you just lose it and you pee it all out. Low urinary output in SIADH because you actually do have way too much ADH now, preventing you from losing the water. Low ADH because you're not making it. High because you're making too much. Diabetes insipidus, hypernatremia. SIADH, hyponatremia. They both affect sodium. Make sure you know which one goes in which direction. DI, very dehydrated. SIADH, overhydrated. And with DI, they're going to lose a lot of fluid. And SIADH will retain too much fluid. So volume overload versus volume depletion. However, both will present with excess thirst. They both will have that polydipsia and a little bit of polyuria because of the pee, but polydipsia for sure. The last one we're talking about is this Sheehan syndrome. The key thing here is childbirth. So infarction or necrosis of the pituitary gland due to hemorrhage during childbirth. Very uncommon in the United States, but it's common in developing countries. Common in pregnant women with type 1 diabetes with pre-existing vascular disease are high risk. Most common presentation is breast involution and failure to lactate. because the prolactin deficiency, you need the prolactin to make the milk. The oxytocin only just squeezes the ducts to let it out. If you have Sheehan syndrome, postpartum pituitary necrosis, you're not going to produce any milk for your baby because you don't have the prolactin. So that's one of the keys with this one. No milk production, involuted breast, postpartum, or something around delivering a baby. And then they develop these things. It's Sheehan syndrome because it has to do with the pregnancy of the baby. Progressively, symptoms of hypothyroidism, hypoadrenalism occur later on if you don't detect it early enough. Why? Because you're not having any TSH made anymore, and you're not making any ACTH anymore because the pituitary is gone. You get a hypotension, acute adrenal crisis. They can be very lethal with these. Mental disturbances are frequently seen. They get some overt psychosis. And the changes go away with appropriate hormone replacement. So whatever hormone they're deficient in, you just give it to them. Lab eval is going to be the hypopituitarism or pan-hypopituitarism we talked about in the beginning of the lecture. You're going to do your labs. You're going to check all the pituitary labs to see where the problem is. Obviously, low free thyroid, estrogen, and cortisol levels, low TSH, FSH, LH, ACTH. Get your imaging done to exclude any lesions that could be there. Now, in long-standing Sheehan syndrome, you see what's called an empty sella. And it's usually be filled with like CSF. So that sella turcica is where the pituitary gland kind of sits in, but it's empty now because the pituitary gland atrophied from the necrosis and the infarct that happened during pregnancy. So you're going to do a scan there, and where the pituitary gland should be, there isn't one. So it's an empty sella. So treatment, you just give them whatever they were low in. So those are the diseases. So as you go through these, again, too high or too low, what are the symptoms they're going to have about that? This you can read on your own. Okay, we are done. These lectures will go fast. Tomorrow we're going to do adrenal or thyroid. I'm not sure yet. Thursday is our interview with Isabella on Thursday, and we're going to do transgender health and MEN disorders on Thursday.